Hi, my name is Jessica Ma, and today I will be presenting utilizing a machine learning mortality model to increase serious illness conversations in hospitalized patients, a cluster randomized controlled trial. Patient physician communication about prognosis, values, and preferences is important to align care concordant to patients' goals and also to improve the quality of care in serious illness. However, fewer than a third of patients near the end of life or their families recall a conversation on prognosis with their physician. Therefore, we set to encourage physicians to initiate these conversations with patients admitted in the hospital using a machine learning model to identify patients who are at high risk of death. We use a validated model developed by the Duke Institute for Health Innovation to identify patients admitted from the emergency room who are at high risk of death at 30 days and 6 months. The model includes patient history and pre-admission features such as prior encounters, diagnoses, procedures, medications, and laboratory values to predict the likelihood of a patient dying during an inpatient hospital stay within 30 days of admission and within 6 months of admission. We use a single site cluster randomized controlled trial design to measure the impact of a notification on serious illness communication and subsequent outcomes. 37 intervention physicians receive an email notification and page notification recommending a serious illness conversation and documentation in the electronic health record. 36 control physicians do not receive a notification and continue to provide standard of care. Our primary outcome is serious illness conversation documentation in the electronic health record during the hospital admission. Documentation is measured by the use of an electronic health record template specific to serious illness conversations. Our secondary outcomes include patient change in code status to do not attempt resuscitation, palliative care consultation, discharge to hospice, as well as 30-day and 6-month mortality. Descriptive statistics of the preliminary data were calculated. In the 6 months of the trial, 180 patients were identified by the model. 51% had documented serious illness conversation during their hospital admission. 19% had a change of their code status to do not attempt resuscitation. 13% had an inpatient palliative care consultation. 13% were referred to hospice on discharge, and 24% died within 30 days of the hospital admission. In conclusion, it is feasible to implement a machine learning mortality model to notify clinicians of patients at high risk of death and measure their relevant health outcomes. Further work will expand notifications to other inpatient settings. Thank you for listening.